Well, good morning, and welcome to Family and Children's Agency's virtual conversation on an extremely important topic. This is actually our fourth virtual conversation, and we will be focusing on the issue of women and substance abuse, overcoming unique barriers and challenges. I want to welcome you. I am Rob Cashel. I'm the president and CEO here at Family and Children's Agency. In just a minute, I'm going to introduce a very distinguished panel and begin the conversation around this very important topic. For those of you who don't know us, a couple of background pieces on Family and Children's. We are one of the largest nonprofit human service organizations here in Fairfield County. We work with children and families and adults and seniors. We are celebrating our 80th anniversary this year, so it's a very special time for the organization. And our work typically focuses on everything from parenting education and family support to foster care. We also provide after-school programming. We have a licensed mental health and substance abuse program, and we work with seniors and the homeless. So with that, I'd like to introduce our panelists for today. And they include John Hamilton, who is the president and CEO of Liberation Programs. John is an internationally recognized expert in the field of addiction treatment and prevention. He chairs the advisory board of the Connecticut Department of Mental Health and Addiction Services, advisory board to the governor. We also have Dr. Margarita Munoz, who is the medical director here at Family and Children's Agency. Dr. Munoz is bilingual and is certified as a child, family, and adult psychiatrist. Dr. Munoz was also vice chair of the Department of Psychiatry at Bridgeport Hospital and has been the medical director of their REACH program. Welcome, Dr. Munoz. And finally, we have Jessica Vivenzio, who is the director of our behavioral health program here at Family and Children's Agency. She is licensed clinical social worker and is certified to treat trauma specialist and is also a certified addiction specialist. So let me welcome all of you and thank you for joining us today. So let's get the conversation started. And Dr. Munoz, I'm going to start with you. And I wonder if you could comment on what are some of the unique stigmas that exist for women in substance abuse and who are dealing with substance abuse issues. What are some of the unique stigmas that they face?
Well, I think that the primary barrier often has to do with gender and cultural views of what substance use is, particularly in women. The rate of substance use in women is actually fairly high. And society often doesn't see that. So that's the first barrier, the view that women don't have issues with substance use when they do. The other issues that we deal with are primarily have to do with their fear of losing their children, losing custody, the barriers that occur due to lack of childcare. Domestic partner violence is another huge barrier with women, and a barrier that we deal with across all genders is the comorbidity with substance use and mental health and lack of accessibility at times. So those are some of the major things that really feed the stigma with substance use and women. But I think the predominant thing that I see is often fear of their children being away, fear of being ostracized by family members or partners as well.
Terrific. John, any thoughts on this issue of stigma as it relates to treatment?
I agree with Dr. Munoz, and it does seem like in most cultures there's this added level of perception and responsibility for women over men, where when they are struggling with substance misuse, there's this sense of shame of how can you do this to your kids? You never hear that statement, at least I don't, to fathers, but there's this added burden on the moms that we've worked with for years, with really one of those major obstacles for stigma. It's like on the stigma ladder, there's a graded expectation that they're to take care of their kids than oftentimes in many cultures the dads. So it just adds to the sense of shame and an obstacle for treatment, and as well as childcare and transportation, which is why we started the first residential women and children's program, so the mom could take the child with her in treatment to address these issues at our families and recovery program. So yeah, definitely, it still exists today, as Dr. Munoz says, and it's still a barrier for treatment.
Right. And Jess, how about you? Yeah.
Yes, I mean, everything that Dr. Munoz and John said, I agree with wholeheartedly. And, you know, in the experience that I have working with women here in our Project Reward program is that there are stigmas, not only for women who have substance use, but even further for mothers. I think there is a gap there. And so much of it does have to do with the expectations and the gender roles that we have, and the kind of old way of thinking that substance use is a moral failure. Just like John said, you know, I think the argument from friends and family is, well, if you loved your kids enough, you would stop using. If you loved your family enough, you would stop using. And that kind of just goes back to the idea that substance use is a choice. And something that we should be aware of too is that the stigma only perpetuates the cycle. It perpetuates isolation, which is a very significant trigger for substance use that we should all be aware of.
Jess, let me ask you a follow-up question about risk. And are there particular risks that women have to develop substance abuse program issues? And John also made reference to a program that he has at Liberation Programs. I know we have one that's a gender-specific one here. So if you could comment on those two pieces, what puts women particularly at risk? And then if you could comment on the benefits of gender-specific treatment.
Absolutely. So risk factors are far and wide, and they are similar for many clients that I have had, but some are very unique. And a significant risk factor is a high ACE score and a high adverse childhood experiences score, and any history of trauma. We did a longitudinal study here in Project Reward a few years ago, just looking at trauma that was disclosed during intakes. And what we know is that during intakes, many people are guarded anyways. And we found out that 94%, I think, of our clients are reporting a trauma history at intake. So trauma, neglect, abuse, all put women at risk for substance use, as do things like poverty and instability and not great or strong connections with the community.
Mm-hmm. Dr. Munoz, thoughts on this topic of particular risk and also the issue of trauma as it relates to this topic?
I agree 100% with Jess. You know, trauma and adversity does increase risk. What a lot of people don't realize is that women biologically are more prone to get intoxicated quicker. So we all know how, you know, Sally may go to a party and have 2 shots and be out of it and be at risk of a date rape or something like that. And it's, you know, there's a biological makeup that occurs in women that makes women more vulnerable to get high quicker and also to develop dependency quicker, as well as withdrawal. And that issue is often not addressed. So women are like, well, my partner also had this and he was able to get it in control quicker, but there is really a genetic and biological basis to being female that creates these vulnerabilities. Women are much higher risk of dying of an overdose than men, as well as having an increase in emergency room visits. So besides the risk of having childhood traumas, just being more vulnerable as female, abuse, neglect, lack of parental involvement, those are all things that are risk factors. The biological makeup in itself, as well as hormonal periods. Women are more likely to be abused during pregnancy in domestic violence. So those are areas. And then, there's that fear of coming out and seeking help are all different factors that play a role. As a child psychiatrist, as well as an adult psychiatrist, I want to share a little data about substance use in girls. So often people don't realize that substance use in the age range of 12 to 17 is higher amongst girls than boys, which is a little bit of a reverse. And I think it has to do a lot with those vulnerabilities of traumatic experiences in early childhood and shame.
Yeah. John, what are your thoughts?
I echo my colleagues, and to Dr. Munoz's point, even NIAAA that sets the guidelines for social drinking will recognize binge drinking for men is 5 drinks, but for women it's 4 because of the vulnerability of alcohol and the way women metabolize alcohol versus men. And social drinking for the guidelines recommends men should drink less than 15 drinks a week, but women should drink less than 10 drinks per week. So to Dr. Munoz's point, there is a higher level of vulnerability just in the quantity for alcohol. We also know, I've done a lot of work with the National Institute of Drug Abuse and they've studied the brain for years, and they can pretty much break down that people do drugs for 2 reasons: to feel good or to feel better. And those that do drugs to feel good, they probably will get through life unscathed because it's all about connection. It's all about sharing experiences with others. Although now with this fentanyl epidemic, 1 pill can kill. So people have to worry about the fact that even a social recreational use could be deadly. But for the most part, we're not going to see them at FCA or at liberation programs in that group of feeling good. Who are we seeing? To Dr. Munoz's point, Jessica's point, those that are needing to use substances to feel better because of trauma. And I'll even go back to what Jessica said with her longitudinal study that 94% recognized trauma. My belief is that of the other 6% is not ready to talk about it yet, because I'm a big fan of Dr. Gabor Mate, who's a Hungarian physician who believes that all addiction is rooted in trauma. So we try to have a trauma-informed, gender-responsive model of treatment throughout all of our agency. It's like universal precautions. It's just first do no harm, and just assume everyone coming in has had a history of trauma. So one of the most important things we need to do for the women that we provide services for is create a safe recovery environment. They need to feel safe first for a recovery to start.
Yeah. So, a lot of comments that you've all made on the connection to trauma and how that has such a critical plays such a critical role in the issues that women can develop in terms of substance abuse. We also touched on some treatment approaches, and one of them, and Jess, I'm going to throw this to you first, was the whole sense that a gender-specific model of treatment can be very, very beneficial for women. So can you talk a little bit about that as it relates to, what you've seen here at FCA?
Absolutely. So even going off of what John had said, gender-specific treatment we do feel is critical to meeting the needs of the women in our community and being able to address their substance use as they have used it for a coping skill. One, maybe to feel better or to feel good, like John said, right? And so the program that we have here is gender specific. It's for over 18 adults. And we, after recognizing the trauma that we were seeing in the clients that we had, we came together as a team and said, we have to do something about this. And so a few years ago, we were trained in the trauma recovery and empowerment model curriculum. I am trained in that, and one of my colleagues is trained in that. And that is something that is a part of our intensive outpatient curriculum at the start. And we really work hard to meet regularly as a team to make sure that everyone is aware of each client's needs and sensitivities and challenges, so that we can work as hard as we can to create this safe environment where women are able to share amongst women. And it's very challenging when there is a group of men and women together, because how can men feel safe sharing in front of women? And how do women feel safe sharing in front of men? It's certainly not like that for everyone. There are clients who come in who might have been able to do so. But what we've seen is that a lot of women do prefer the gender-specific treatment because it is a bit more trauma-informed, and we are able to focus on that safety foundation before we do any other type of work.
So you talked about safety. And Dr. Munoz, I wonder if you could comment on that as it relates to gender-specific treatment, but also how important the issue of safety is in terms of treatment.
Well, I think and this is not to discount that men have trauma, they do. But I think because sexual trauma is often very common in this population, it's almost as if the substances try to numb the pain or the traumatic experience or feed into a dissociative state. It's really important to create that atmosphere of safety where they can also talk openly with other people that could relate to their circumstances and not be judged. Lots of times there's not only shame about the substance use, there's shame about the trauma. Lots of times they haven't been validated for the trauma. You know, there are all sorts of misperceptions that are created, like, oh, you shouldn't have worn that outfit, or you shouldn't have had that extra drink. You know, that's what led to this happening. So there's a lot of blame, a lot of shame that goes in there. I think the commonality too of being female, motherhood is extremely hard. You know, now in society, you know, we're expected to be a good mother, to work, to do all these things. It's a great burden. It's a great burden for someone who doesn't have mental illness or substance use, but compound that on top, just being in an atmosphere where you could admit to this and be supported and not blamed for being a bad mother. The impetus for a lot of these women are their children. They love, they feel, and they want their family members and their kids to have a better life. And that's a beautiful process that's created in this atmosphere of support.
Yeah. So you made reference, Dr. Munoz, of mothers who are dealing with addiction issues. And John, you mentioned your program. And I know one of the realities, sadly, is that many people who see women who are dealing with addiction issues, who have children, might say, how can you do that? How can you allow yourself to become addicted when you're a mother and you're, how could you, if you will? So in your program and in your practice, John, what are your thoughts around that, and how to help a woman who has children kind of deal with that feeling of guilt and blame?
It's a great question, Rob. Yes, that's why we created that first residential women's program 20 years ago. And sadly, there's less than 100 beds in Connecticut for being able to bring women in with their children. And our program is the only one in the state that allows a mom to bring in more than one child. You can bring up to 2 children. So we've been fortunate to partner with DCF over the years, because for some, if they've been, depending on where they are in their struggle with substance use disorder, they may have already lost kind of their child and needs to get reunified with their child on the back end. But on the front end, we're really trying to offer them hope, to empower them as moms, and offer them, as Jessica said earlier too, it has to be more than just recovery. They have to, there's issues around homelessness and poverty. And we actually, since Families in Recovery, we actually created a residential program to be a feed called Ginny's House in the same building in Norwalk, where it's permanent supportive housing, so a woman can actually come with her kid. So we're basically offering them hope. And to Dr. Munoz's point, it's like, yes, we're dealing with this trauma that, as I said, people do drugs to feel good or feel better. The women that we're working with, they're doing it to feel better. It's not the trauma that what happened to them, it's what's happening and what happened inside them. And it's, again, the connection of doing drugs to feel good. It's the exact opposite. It's disconnection to self, disconnection to their community, disconnection to their kids, disconnection to their emotions. So the goal of our therapy is having them have the ability to stay present, to be comfortable in their own skin, to be able to be a sense of accepting and forgiving of themselves, and be able to just feel that sense of hope. I mean, it's really a major transformation for these women who have not felt hope in many years or ever, to really be able to build that hope. And by empowering them in their role as moms, that helps them build that hope, and to work with them and do whatever it takes to have them feel lovable. Because even though we talked about the ACEs study, right, which is, you get these 10 questions of abuse and neglect and all this toxic stress people can have. But what I found most interesting in the ACEs study is that there is a protective factor, that if those kids as adults have one consistent, supportive adult in their life, and it doesn't even have to be a parent, but it's great if it can be a parent, consistent, supportive, loving person in their life, that'll transcend all the trauma that they've had, and have them be able to be the resilient individual that they can be. So we try to connect the dots with the moms that come into us and let them know that they can break the pattern of intergenerational trauma and addiction, and make a difference with their kids, because that allows them to keep their eye on the prize. And it's very, very empowering for them to really feel like they can make a difference in their kids' lives.
Yeah. Jess, I see you shaking your head. So what are your thoughts on this?
Yes, no, it's so, everything that John is saying is so valid. I think one of the very first questions that you had brought up, Rob, was like, what are the unique challenges for women? And these are what they are. The stigma is a challenge, and the access to care is a challenge. And having providers in the community like Project Reward, like Families in Recovery, are so critical. And, unfortunately, there's just not enough, right? But it's so important to even have these conversations, and I'm so glad that we are.
So switching a bit, sometimes there is confusion about what is a substance abuse disorder. And I'm going to pose this first to you, Dr. Munoz, around what are some of the signs and symptoms that are often evident to, more often than not, significant others or family members that might be suggesting there is an issue here?
So I'm going to start off by correcting you a little bit, because we
Go
don't
to it.
really use substance abuse anymore. We use substance use disorders, because I often start these conversations with like, when we were little kids, right? When I grow up, I want to be a doctor, right? When I grow up, no one says, when I grow up, I want to have an addiction, or I want to have a substance use disorder. So understanding vulnerabilities as well as genetics is really important. And we've talked a lot about those risk factors, as well as, I'll put a separate spin. We could have a separate talk on resiliency factors that can be protective. And, so I have a lot of hope that this can change. I mean, this is the first step, having a dialogue, raising awareness, destigmatizing, are all really vital things. So substance use, there's psychological and there's physiological symptoms related to it, right? So you can have certain substances that really cause physiologic symptoms and withdrawal. And withdrawal is a real thing, and it's a huge barrier in getting better. If you know you can take something and feel better or be miserable without taking it, most people are going to tend, no matter how, to take the thing that's going to make them feel better. And in some cases, as much as they want to stop, it is so hard to stop. And that's not just, we think of opiates in that model, but so many substances can cause withdrawal and discomfort. So it's not just necessarily the high, but it's what happens after that, process that really keeps people, going back for more. It also causes biological changes in your brain. So this becomes like almost like an OCD, an obsessional thing. And that's a really hard change. But talking about symptoms to watch out for in yourself or others is kind of like obsessional thinking. It's similar to mental health signs almost, changes in sleep, changes in appetite, weight loss, weight changes, secretive behavior, money going missing or misspending, not showing up for work or school. Erratic behavioral changes can happen as well. Depending on the substances, pupil changes. They're more obvious things, slurred speech, difficulty with arousal, but substances have mental health effects. So you might notice mood changes like depression or elevation in the case of cocaine or more elevating substances that often can mimic mental health issues. In severe cases, we see respiratory depression and seizures as well. But really looking for those changes. And, I look at substance use across the life cycle and catching some of these symptoms, earlier on and observing them later. Now, the complexity also arises because about half of people with mental health also will have some substance use as well. So that complicates things, right? Because what came first, the chicken or the egg? And oftentimes you will have both. You will have someone with depression who's using alcohol that then increases the depression, or you could have someone with a cannabis use disorder who has an increase in panic, and there's a poor medication response or poor compliance, so there are all these factors that we all have to look at and consider. But I think having some awareness of these symptoms and how they can present, also some awareness that there may be exacerbation of comorbidity, even though it starts off as almost a self-treatment of comorbidity or all important factors.
Yeah, all right. So we had a question in the chat, and we have a few questions in the chat, but let me pose this to you all, and maybe John, you can start us off. And the question was, how can you get services for these issues without a referral? How can you get services without a referral?
Well, it's a great question. And again, going back to Dr. Munoz, clarifying the new terms of how we're looking at this as a substance use disorder. It's a continuum, a substance use disorder, mild, moderate, and severe. Honestly, there are people with a mild substance use disorder that may not need formal addiction specialty treatment that could go to a therapist or try to reduce their use with some pretty good results. So we're working with the people that have lost control, have obsessed with use, continue using despite consequences. And a big part of that is being able to tailor your intervention based on your relationship with that person and that person's relationship with the substance to really have an assessment of what they may need. So they look through these dimensions from the American Society of Addictive Medicine. So we first need to know if the person needs a detox. We've even now changed the language on detox. We don't call it detox anymore because that's pejorative. We call it withdrawal management. So if the person has an opiate addiction, the person has an alcohol addiction or a benzodiazepine addiction, which is so pervasive with women, they will need a medical monitored detox. So that's the physical recovery. Then they need to go into treatment, outpatient or residential, for the emotional, psychological recovery. And ultimately, they have to find something that gives them greater meaning than that substance, which is a spiritual recovery. But it does take into account their level of motivation and their willingness and ability to come in. So that's going to determine the services that are going to be provided. Trouble is, most in our system provide abstinence-based care, and they may not even be willing to stop yet. So we have to assess that need and then offer harm reduction. So it will be tailored by what the person is looking for. And Demas has great resources. Connecticut Clearinghouse for Women has great resources. They have, now we have 988 for mental health resources. We have 211 for local meetings and resources. So there are absolute resources that are available to people regardless of their ability to pay that we have. We have a robust system, but it's not so much what we have. It's our ability to engage people, right? Ultimately, it's all about connection. That's what this Johan Hari says. The opposite of addiction is not sobriety. The opposite of addiction is connection. We've got to connect them to care. We know most people come to us because they're either mandated or mom-dated. They've got pressure from family. They got pressure from the courts. So we want to have some level of internal motivation, as we talked about earlier, remove some of those obstacles that are getting in the way of treatment, because only 1 out of 10 women that could actually benefit from treatment will seek out treatment this year. So we're trying to keep those other 9 alive, first of all, particularly with the fentanyl epidemic, but try to find ways to engage them and find out what do they need in our continuum of care, because we definitely have robust services here in Fairfield County for women who are looking for treatment.
Jess, what are your thoughts as it relates to, services and getting those services without necessarily having a formal referral?
Absolutely. Thank you so much for tossing it over. So it depends on, just like John said, it depends on the stage of change that the individual is in. But there are many, many programs where they are able to refer themselves. They're, at Project Reward, you do not need an outside referral. They can call me, and this does happen frequently, actually, where clients have said, I was there a couple of years ago and I wasn't ready. Now I think I might be ready. Can I come in and figure it out? Absolutely. And I think harm reduction, like John mentioned, is so critical. And I think cycles back to the stigma question. I think a lot of people really struggle with the idea of harm reduction. Well, not passing out, having safe use kits, fentanyl testing strips, all of these things. And I know many, many people have an issue with that. And what harm reduction's goal is, like John mentioned, is to keep the individual alive until they are hopefully able to say, I'm ready to address this, because of the connection to trauma, there are so many demons that these individuals are facing that sometimes the reason that they use is because it is too much. It is too much for them to hold individually. And it can also be really hard and really scary to trust people when you may not have had people in your life that you could have trusted growing up. And how are we going to trust them with such a vulnerable piece of ourselves? So I think the harm reduction piece is really important for individuals, families, systems of care to also understand and recognize as a valid form of treatment. and know that there are many programs in Fairfield County where clients are able to refer themselves and they do not need to be mandated to be in treatment.
And if I can just add and piggyback on what Jessica's saying, there is anyone who walk into any of our programs, self-referred and get treatment sometimes that same day. One of the other pieces that I thought is just really important to mention regarding stigma, because again, depending on people's perception, sometimes a mental health issue is one more run on the stigma ladder than a substance use disorder issue. But even in the existing addiction treatment system, there's still stigma in medication-assisted recovery. And here's what we know about medication-assisted recovery. And Dr. Munoz, I'll have my back on this one because she knows it works. We have a fentanyl epidemic. You know, we lost more lives in this country last year, 107,000, than breast cancer and colon cancer combined. It's just tragic, right? So 1,300, over 1,300, close to 1,407, I believe, in the last count. Individuals died in Connecticut. We've got to keep people alive. That's a pathway to recovery. There's multiple pathways to recovery, but death is not one of them. So we have to really look at doing whatever it takes to keep people alive. And medication for opiate disorder, for fentanyl, is the gold standard. We know that if a person who is an opiate addicted individual is not on one of the 3 FDA medications, which is either injectable naltrexone, buprenorphine, or methadone, if they're not on one of those 3 medications to quiet their brain, ultimately quiet their brain so they can stick around, it's ultimately skills over pills, self-regulation, mood regulation, but they have to stick around. And they're not going to stick around and stay in sustained recovery unless you quiet their brain. So if you're not on one of those 3 medications in the first year of recovery, you have a 90% chance of relapsing. So if somebody's not being offered one of those 3 medications, it's nothing short of malpractice, that they're not giving their loved one the, if a family member finds out that their loved one was not given the gold standard of treatment, what are they offering them? I mean, they still have the choice not to take it, but we have to offer them because we don't even have the data to know who's that 1 out of 10 that doesn't need the medication. What level of what we call now recovery capital does that 1 out of 10 person has that doesn't require them to have that medication to quiet their brain? In the meanwhile, we should be introducing it to everyone, and we're not.
Yeah. So you've both mentioned, and you made reference to it too, Dr. Munoz, harm reduction. And many, many years ago, I was actually certified as an addiction specialist. One thing is clear, and what I've already learned is things have dramatically changed since I was certified many years ago. And one of the hallmarks back in the old days was that a key component of helping people with this issue was getting involved with a self-help group, in particular AA. And that was often seen as foundational. And as a clinician specialist, one would work extremely hard to get people engaged in AA. And I'm curious, again, given how things have evolved and changed, where are we now as it relates to that whole piece of AA as part of the tools, if you will, which in the old days, which dates me, was foundational to the work. So Dr. Munoz, what's your current thoughts as to AA and how it relates to what we're talking about?
So I think they're different strokes for different folks. One type of treatment, one size does not fit all in this. Everybody is at a different stage, as Jess said. And John, you also mentioned we have to save, they have to be alive in order to. So the first thing is, safety, safety and health. And, there's a progression. This is not, Jess, I know in our pre-discussion you had said, substance use is not linear. It ebbs and flows So I think, if you are at that stage of change where you're ready to abstain, an AA type model is probably a good model for you. But there are relational models, there are CBT models, there are trauma-focused models. So don't give up. If you try AA and that didn't work for you, or NA, there are so many different modalities out there that can help you. Along with the medication-assisted treatment. Medication-assisted treatment is not just only for opiate use, it can be life-saving for opiate use. And you can have healthy babies and be on MAT. You know, I have plenty of women that have beautiful babies, you know, and we're on buprenorphine. So look, you know, there's the stigma that, oh my goodness, it's gonna, you know, you're probably going to harm your child more by not going on and yourself by not receiving the appropriate level of care. So, you know, with alcohol use, with even cannabis use, if you're having withdrawal symptoms or dysphoria or mood symptoms, there are other treatments that can be helpful. So, you know, decreasing that stigma as far as MAT, you know, it's not just withdrawal management. I always ask, well, what did you get from the substance that you used? Well, I felt calmer, I felt less anxious, I felt less depressed, I got rid of my nightmares, you know, so targeting what really matters to them is really key. And, you know, keeping in mind, having a dialogue as to, you know, what would be a good fit for that point and time at the stage that they're at.
Terrific. John, Jess?
Oh,
Thoughts
I'd love to
on,
jump in here. I really think one of the most transformative things in the field that have happened over the last couple of years is the recovery movement, and particularly the introduction of recovery coaches. And I'm on CCAR's board, so I'm a big fan of CCAR, who actually through their recovery coach program promotes, as Dr. Munoz says, the multiple pathways of recovery. So 12-step recovery has saved millions of lives, and it is a community of recovery, and it saves lives for some, but not all. Not everybody finds that as their community of recovery. So for women, there's women in sobriety, there's smart recovery, there's wellness-based with yoga, there's religious recovery. Somebody can find recovery in their faith community. There's active sober recovery with Phoenix Multisport and Fit for Recovery and Adventure Recovery. I mean, there's so many different pathways. So for the recovery coach, they ask the individual, you know, how can I help you in your recovery today? And I think more importantly, what does recovery look like to you? So they can tailor the pathway to what that person is going to connect to. Because remember, it's all about connection. So they have to connect to a community that that's comfortable for them. And it's just like, what's the right medication for somebody to be on? And what's the right treatment? The treatment and medication they're going to take. Because what we do know, regardless of all these multiple pathways of recovery, we know there's compelling data that shows that if you actively participate in your recovery pathway, the longer you do that, the better the prognosis, since this is a chronic disease, that you're going to have stable recovery. So 90 days is the first milestone. It's like a natural healing process, like you broke a bone, which interestingly enough, in 12-step recovery, they say go to 90 meetings in 90 days. They didn't even have the data, they just knew. And then the first year is also the next big milestone. If people can say in sustained recovery, then every anniversary date after that is a sober date. That becomes key, is whatever they're going to actively participate in their recovery is the right pathway for them. And by the way, harm reduction is a pathway to recovery.
yeah. Jess, thoughts on your part?
Hi, can you?
Hi, I'm sorry.
I'm so sorry. I
We
was
lost you for a
frozen.
minute. That's
I was
okay.
very
So-
excited to speak, and then I couldn't see anybody.
Good.
So
we got you.
sorry.
So any thoughts on this issue of?
Yes, absolutely.
tools?
So I think the more important thing to recognize here is not AA specifically, right? I think to John's point and to what you said earlier, Rob, is that back in the day, right? It was, all right, go to AA, build a community, get support. And we still want them to do that. It just doesn't have to be AA specific or NA specific. We have had success, women who are in recovery for years, and it's because they found a community in Bible study. They started a book club, and it's more about the connections that they have. And one of my favorite questions that we ask when women come in at their evaluation is, what gets you through your day? What gets you out of bed in the morning? And sometimes at first they have a very difficult time answering that. And so then that's our challenge. All right, what do you like to do? And let's work on reconnecting you with society. So when you do get out of bed in the morning, you have multiple different sense of purpose that is fluid. Our purpose every single day is going to change. And it doesn't have to be one very specific thing. It can be a culmination of things that helps them to not feel alone, that does not perpetuate the cycle of isolation, and really just gets them to be re-engaged.
Wonderful. So the three of you have stimulated a number of questions in the chat. We are not going to get to all of them, but in the time we have, and if I could ask you just to be a little concise so we can hit as many of these questions that came in. One of them I think is really important to hear your thoughts on, and that is, how can men be allies and be of support for women who are dealing with this particular issue? How can men be allies? So who wants to jump in first?
Hey, I know this one. I'm a man.
There you go.
Which, by the way, I'm not a woman, so I feel humbled to be on this panel. So, but as a man, I could say that as a partner, it's really genderless in a sense. Is have your partner's back. Don't take it personally. Depersonalize and not make it about you. In my private practice over the years, I can't believe how many times I've had to say, it isn't always about you. And oftentimes that's when men struggle. It's like, how can she do this to me? Not understanding this chronic addiction as a disease and taking it personally as if she was doing it maliciously to hurt them. So that sense of being able to accept and forgive your partner allows you to ultimately accept and forgive yourself and allow yourself to be human and just sit with your humanness and maybe grieve some of the sadness and loss in the past and move forward. There has to be this mirroring trust, because oftentimes men that I work with women, the obvious trust issue is, will she relapse? And, can I trust that she's going to stay in sustained recovery? But then for the woman, when you ask her about trust, she wants to know, will he hold this over my head for the next 20 years? Because that has to be resolved as well. There has to be a sense of staying in the present, moving forward, having a sense of honesty with each other. The more you show your humanness, the more you're lovable. Be authentic, be real, be present with each other, and be supportive.
Wonderful. Thank you, John. Dr. Munoz?
I just want to also say that family members of people with substance use need support as well, because that's also going to help you to grow in your relationship with your partner or family member. So there are resources for families. I would definitely urge you, because if anybody knows Melody Beattie, she's written a lot on codependency and how we kind of unconsciously, a lot of family members have this caretaking role, but also fuel into the dependency. So having that awareness, coming from a place of compassion, but also maintaining boundaries and accountability are really an important part of the process, as well as your own self-care. And this can really make the relationship grow and be tighter.
Yeah. And thank you for your answers, both of you. And just to expand it a little bit, because this question, of course, was how can men be allies? But maybe we can say men and family members, how can they be allies as it relates to women who are struggling with this issue?
Absolutely. And such a big part of that, I think, is keeping communication open, just like Dr. Munoz and John had mentioned, and creating an environment as much as you can that is not judgmental. As someone who might be struggling with their substance use, there is so much shame, there is so much guilt, and when they are in an environment where they feel as though they can't share because of that shame and guilt, it is even more difficult when they feel as though they are being judged or not understood. Being strengths-based is really important too. Not necessarily not setting appropriate boundaries, because that is incredibly important, but really highlighting what that person is doing for themselves, for their family. Even I am so happy for you, you made it through the entire day, or I am so happy for you, you called me when you had a trigger. So keeping communication open, creating as much of a safe and open environment as possible. And even things like offer to go to a meeting with them. They might say no, but I would be willing to bet that the offer means more to them than if you did. So little things like that.
Interesting question here, and this may be the last one we're going to have time for, coming again from the chat. And the question that someone listening is interested in hearing from you on is, how is the commercialism, I would say legalism as well, of cannabis affecting substance use treatment? So how is this commercialism affecting substance treatment in your eyes? Dr. Munoz?
Oh, that's a loaded question. So for years, there are positive aspects of it. It's the decriminalization, preventing people from serving time, especially certain marginal populations that were really targeted in that process. I think that we have to view cannabis use the way that we view alcohol use, right? You can use it for recreational sort of, I forgot what wording you used, John, but, to sort of be good instead of better. When we look at cannabis use, we have to look at if there's impairment or dysfunction associated with it, if it becomes an obsession. There are specific neurotransmitters and genetic profiles that really predispose people to psychiatric illness with cannabis use. So that's something that research is being done, and there should be some awareness of that. So I think that just because it's become legalized, it doesn't mean that if you have high usage, if you're spending excessive amount of money, if it's affecting your impairment, it can still be a problem. And I think that also the impact of cannabis on pregnancy and breastfeeding also is an area which is not something that is necessarily being addressed. I would love for marijuana to be FDA approved because it would provide guidelines as to THC and cannabis content, because right now you could get really high THC content, which can increase mood issues and, all sorts of things. But that's not, so being a smart consumer, being aware of these things, educating yourself, not just listening or looking at web pages, but go to the SAMHSA website, learn more about these and being aware that there are signs and symptoms that could be developed. My other major issue has to be as a child psychiatrist, because I think the legalization is causing, at least I see this in the school-based programs, use at an earlier age. And I think there really has to be a crackdown on those smoke shops that that aren't carding people and sell to the underage, because I'm seeing a lot of that in Fairfield County. So because it is very different, the impact of cannabis on the there's a reason why it's legal after age 21. It really does have an impact on the developing brain. So keeping all those factors into play. So it's a two-edged sword. There are benefits of it, but there are also lots of risks involved that we have to raise awareness of.
Yeah. Wonderful. So John and Jess, we are literally coming down the home stretch, but any comments that either of you would like to make on this issue of the commercialization of cannabis?
Sure. I just want to point out again, as Dr. Munoz said, we know that what causes addiction, substance use disorder, is increased exposure at an early age of substances increases risk, and also increased exposure to toxic stress, which is another piece that we need to help people with and out there and not be stressors in their life. So they kind of put the cart before the horse. We jumped the gun because we didn't really have the data to understand marijuana and its long-term use. There's one study from New Zealand, and it shows reduction in their livelihood and graduating college and intelligence. And that was with a lot smaller THC content over the years. Now, the bigger issue is this exposure to the potency of THC. We need to put some limits on that. So we need to obviously not have it be on the developing brain, which finishes at 25 for women and 24 for women, 25 for men. We have to not have that exposure to a developing brain and reduce the potency or have caps on potency in Connecticut to, like, I think they just did in Colorado, or looked at like 30%, because you could get THC up to 90%. We don't know what level of harm that would cause. So we really have to be careful of that. Increased exposure increases risk. And we have to, again, show people how much we care before we show them how much we know. Otherwise, they don't really care how much we know.
Wonderful. Thank you, John. Any final comment here, Jess? And
Yes, final comment. I think it's very important, just like Dr. Munoz said, that we treat it similarly to alcohol and any other thing or activity that could be something that you are addicted to. It could be music, it could be chocolate, it could be sex, it could be gambling. And regardless of if it's alcohol, cannabis, gambling, if it's causing a negative impact in your life, chances are you would benefit from having some support around that.
terrific. Well said. Well, listen, we are coming to the end of our hour together. I want to thank all of our panelists so much. I think it's pretty obvious they are true experts in this field. And I hope for everyone who has tuned in that you've been able to take something important away. I know I have. And I can't thank you enough. We will have a link in the chat for some resources. We will also be sending out an email for resources to those people who were signing up for today's web conversation. And finally, be on the lookout for the next of FCA's virtual conversations. We are looking to do these about 4 times a year. And we will hopefully come up with a topic that, again, will bring some important information and education to those of you who tune in. So again, Dr. Munoz, thank you so much. John Hamilton, Jessica Vivenzio, you did a great job. Thank you so much.
Thank you, Rob.
All right.
Thank you.
Thank you.